Good afternoon, everyone. Welcome to Unit 2, Session 2 of the ACEs Aware Ventura County Virtual Lecture Series. We're going to give folks just a couple of minutes to log in. On this screen are a few reminders about finalizing your registration and how to complete the evaluation. This lecture is being recorded, so you'll be able to access it on the ACEs Aware Ventura County website. And while we're waiting, go ahead and introduce yourselves in the chat box with your name and organization. And make sure your microphones are muted as you come in. And remember, anyone who registers is entered into a drawing for a custom ACEs Aware Ventura County prize. So make sure you're registered, and the link is going to be in the chat. And in your registration and evaluation, make sure you've noted whether you need continuing education. And those who are seeking CEs, you must be present for the entire session in order to receive those credits. While we're waiting, please go ahead and introduce yourselves in the chat box. Hi, everyone. I am Lucy Marrero, and I am one of the clinical advisors for ACEs Aware Ventura County. And before we begin, we're going to hear a few words from Dr. Landon.
Hi, everyone. Thank you for joining us for this session that is part of the AAVC Provider Training Lecture Series. We hope this session is both informative and engaging for you. Don't forget to register and complete the evaluation so we know who our audience is and how to improve in the future. All who register, including those who are watching this as a recording, will be entered into a raffle for a special ACEs Aware Ventura County prize. This lecture is being recorded, so you can have access to it on our website at any time. Thank you for joining us on our mission to bring better help, better health, and better hope to Ventura County and beyond.
Welcome, everyone. Our speaker today is Dr. Stephanie Marcy. She'll be presenting on increasing motivation and decreasing perceived barriers. Dr. Marcy graduated from UC Berkeley as a psychology major. She pursued a master's degree in child development and then went on to receive her PhD in clinical psychology from Boston University. She received extensive training in clinical intervention and assessment with children, adolescents, families, and adults. On finishing her degree, she moved back to LA to pursue a 2-year postdoctoral fellowship at Children's Hospital Los Angeles. She has a strong emphasis on trauma work with typically developing children and teens, as well as those affected by developmental disabilities. After fellowship, she joined the faculty at CHLA, and a couple of years later, the faculty of USC Keck School of Medicine, where she has been since then. She's currently an associate professor of clinical pediatrics, as well as medical director of integrated behavioral and mental health services in primary care within the AltaMed General Pediatrics Clinic at CHLA. Currently, she provides individual and family therapy for children and adolescents with a multitude of presenting conditions and does comprehensive psychodiagnostic assessments to help provide diagnostic clarification and determine appropriate social, therapeutic, and educational interventions. Dr. Marcy is also an active supervisor for pre and post doctoral psychology trainees, and she's a member of the Developmental Behavioral Pediatrics, or DBT team, providing instruction to medical residents and DBT fellows in the areas of assessment, child development, and doctor-patient communication skills. Dr. Marcy is often retained by the Ventura County Public Defender's Office as an expert witness and clinical evaluator in the juvenile and adult forensic settings. She lectures to many different groups in the academic and medical setting on a variety of topics, including ACEs, eating disorders, and sibling caregivers of children with chronic illness. After the lecture, Dr. Marcy will be responding to your questions. You're all encouraged to submit questions via the chat box to our speaker to answer during the Q&A session. And now I'll turn it over to our presentation.
Thank you so much for that introduction. Looking forward to talking with everybody today about ACEs screenings and increasing motivation to complete ACEs screenings in your practice and addressing some of the barriers that people may expect to encounter in adding this to your clinical practice. The objectives for today's talk are first to define adverse childhood experiences, which we call ACEs, and their prevalence, the health disparities in these data, what a toxic stress response is, and related impacts on health, including the underlying biological mechanisms. I'm hoping you'll be able to describe at least 5 potential barriers to clinical implementation of the screening tools that you may use, develop a clear plan for intervention and risk mitigation as it relates to promoting resilience and trauma-informed therapies, demonstrate how different motivational interviewing strategies can be applied in the context of ACE screening, and education about resilience and self-care. This is the ACEs Aware mission statement that serves as a reminder to everyone attending this lecture. We want to emphasize that the purpose is to change and save lives by helping providers understand the importance of screening for ACEs and training providers to respond with trauma-informed care, which can mitigate the health impacts of toxic stress. I want to go over what the purposes of screening for ACEs are and also give some guidance on what they're not. What I don't want people to do is to simply check a box that you screened for ACEs and then not do anything about it or follow up. It's not a substitute for engaging in a conversation with your patients and families about the experiences that they have had. One of the main purposes of screening is to facilitate prevention and early intervention. It's also to provide risk mitigation for the impacts of toxic stress on the physical and behavioral as well as mental health impacts. It's to be used as a tool to guide the care that you will provide, and a platform that you can jump off of to educate patients and families about adverse childhood experiences and toxic stress. This talk is really intended to challenge some of the misconceptions that providers have about barriers to providing ACE screenings in a timely and effective way, and to provide tools that will allow providers to feel equipped to address and mitigate these myths or potential actual concerns like lack of resources, should they arise. With appropriate training and motivation and support that I hope will be achieved during today's talk, the idea is that each provider will have increased confidence and skill in applying these principles to their practice day to day. This slide talks about the application of your ACEs screening, some guidelines to help you know what to do with the screenings when you complete them with your families and patients. We know, first of all, that there's high co-frequency of different adverse childhood experiences. So you may see that there are multiple experiences that families and children endorse, not a single one. Each individual patient outcome will be based on a combination of cumulative adversity. I want everybody to think about that. This is among the different guidelines that ACEs Aware provides us: combination and cumulative adversity. The other thing to think about is that there also are not just the ACEs, but protective and mitigating factors that can serve as barriers to the outcome. And this is really the dual-sided approach to effectively screening and providing adequate care for patients, keeping both the adversity and the protective factors in mind. They also discuss using the screening in a probabilistic way. Well, what does that mean? That the person is not doomed to have a particular outcome, that you're not going to scare the patient by saying, oh no, you have this high ACEs score, you are going to have diabetes and heart failure and early death and mental health problems when older. But we know from the data, the research that's been done for many years now, that there is a higher risk. And our jobs as providers are to help alert the patients by screening them effectively and doing what we can to decrease the risks so that they can go on to have happy and healthy lives. This next slide is a nice visual overview of the cycle of adversity and negative outcome. Exposure to ACEs, in particular in the absence of protective factors, we now know can alter the biological stress response in the individual. It can also disrupt the development of neuroendocrine, immune, metabolic, and genetic regulatory mechanisms, and in some cases lead to a toxic stress response. This will increase the risk for health problems, physical, mental, and behavioral disorders in the child or individual's future. While the psychiatric and behavioral implication of ACEs and toxic stress are those most commonly recognized, the neuroendocrine and immune dysregulation characteristics of the toxic stress response has various clinical implications. It's important to recognize that the purpose of ACE screening is not specifically to identify the ACEs per se, but to identify patients at risk for developing toxic stress or other post-traumatic symptoms and experiencing ACE-associated health conditions. This algorithm pertains to the ACE score, which is part 1 of the PEARLS screening tool, whose associations with health conditions are most precisely known. While social determinants of health may also increase risk for a toxic stress response and should be addressed with appropriate services, it should not be added to the ACE score for this algorithm. Social determinants would include things like housing insecurity and food insecurity that can certainly affect the sense of safety and security and consistency that a child has that can be related to stress and anxiety. Like any relationship, it's important for the provider and patient to have trust, mutual respect, and effective communication. It's important for the provider to include the patient in their own care, to make them a part of their own team, to facilitate a collaborative relationship. As is true in any case, it's important for the provider to also be sensitive to the patient's individual and cultural background and beliefs. By maintaining these guidelines, it increases the likelihood of a positive outcome for the patient. This is an overview of trauma-informed approach to clinical care and gives some nice points on specific components that should be included in your trauma-informed approach. As I alluded to earlier, the ACE scores alone do not cover the entire breadth and depth of what you will want to eventually cover in your interactions with the patient and family who have higher ACE scores. Some things that will not be captured by their ACE score alone are the severity of adverse experiences, the frequency, whether there were single or multiple perpetrators, whether this child or family has disclosed some of these experiences in other contexts or to other people, the ages where the adverse childhood experiences occurred, what the child's premorbid functioning was, and what positive or protective factors the child may have in their life. If you use the de-identified screening tool, you may not even be aware of what the specific ACE or ACEs are that the child experienced. For example, regarding whether this is information that has been disclosed prior to sharing it with you during your visit, there are implications about how it was addressed and handled in prior disclosures. What if the child did disclose some type of trauma or abuse before and nothing was done, or worse, perhaps, led to a negative or punitive result for them? This is something you would want to be aware of and integrate into your approach with the child, because they may be fearful or not be hopeful that you will be able to do something different than what was done before. In general, the provider discussion should guide education, intervention, and evaluation in a trauma-informed manner. It should always be sensitive to the patient and family's needs and integrate that child or family's readiness for support and accessing the resources that you may provide. ACE screening involves assessing for the triad of adversity, which includes the actual ACE score, the clinical manifestations of toxic stress or post-traumatic symptoms, and the ACE-associated health conditions, otherwise known as AAHSCs, and protective factors. The first two components are used in assessing clinical risk for toxic stress, and all three are essential to guide the effective responses within a trauma-informed approach. To reiterate, ACE screenings are a tool to guide evaluation, intervention, and education of patients and families. It's not just something to check off that you completed, and it's certainly not intended to be punitive, judgmental, or harsh. In doing these screenings, it can be anxiety-provoking. Therefore, it necessitates follow-up discussion and ongoing sensitivity in your approach with the child and family. There are many different potential concerns that providers have in approaching ACE screenings within their primary practice. For example, lack of time to ask and appropriately counsel families, concern about causing distress or harm, or essentially re-traumatizing the already traumatized patient or family, lack of confidence in how to appropriately ask or respond about these events, discomfort themselves in asking, lack of adequate mental health or other resources to offer to the family should you determine that there are things that need to have follow-up care, feeling inadequate to help effectively, feeling that ACE screenings are inappropriate and even unethical, a concern that it may strain the doctor-patient trust and relationship, that doing so will put the child or family at greater risk for child welfare agencies like DCFS, that asking the questions might offend the patients or parents, and finally that there may not be reimbursement for this additional care that will be required of them. There's evidence to suggest that the concern that it strains the doctor-patient trust is unfounded. ACE screening has been documented to be acceptable to both patients and providers when done correctly and sensitively. There's emerging evidence that shows it may actually improve patient trust in providers and satisfaction with the healthcare experience, in part because it serves as a welcome bridge to needed prevention and buffering interventions such as parenting guidance, economic and legal support, educational advocacy, and logistical supports for the child and family. By the end of this talk, we hope that you will have strategies to address many of these interventions using a motivational interviewing approach and trauma-informed care principles. This is why it's so important to train providers in trauma-informed care, so they can be the first tier in this interaction with the patient. Often, families may neglect seeking outside resources and supports, but will show up to the doctor's office to ensure that their child is healthy medically, which gives you both the responsibility and opportunity to make a big difference in these visits. While all these objections that I stated earlier may be based on physician actual experience, such as lack of time or discomfort, it is all relative and fluid and able to be remediated with proper training and experience. In this slide, you'll see the same concerns that were discussed previously that providers have raised as barriers to doing ACE screenings in their practice. However, these concerns are valid but not insurmountable. As providers, we need to be aware of possible additional factors or information that will be disclosed as we explore some of these ACE and traumatic experiences that our children and families have had. Being prepared about how to discuss these things and being sensitive to the patient's comfort and willingness to disclose is a very important aspect of providing good trauma-informed care. Some of these discussions, unfortunately, may end up leading to necessity to report to an outside agency like Child Protective Services. Other times it may generate natural and appropriate referrals to agencies that can be supportive to the family and help mitigate some of the stressors like a food bank or a legal resource. The de-identified PEARLS tool is designed to not prompt for specific disclosure of the actual adverse experience or trauma that the person experienced. Rather, to allow them to provide a total score without disclosing specifics. This is due partially to the fear that some children and families have that there will be a punitive response or a response that they receive as punitive, such as reporting them to Child Protective Services. Unfortunately, there are many experiences that families will share where it has been experienced as something negative and has not been perceived as something positive or supportive for them. From my own clinical experience, though, and input from other local providers, people are identifying their responses even when not required to, perhaps putting a check mark next to the specific adverse childhood experience that they had, even when there's not a space to do so. It's important to recognize that you can have two patients with the exact same total ACE score with a significant amount of difference in terms of how they look clinically, medically, and behaviorally. And it is our responsibility as providers to provide the ongoing discussion and exploration of these reactions and experiences they've had. With knowledge comes responsibility, and as a provider, in completing these screenings with your patients and families, it is important that you continue to discuss and address these issues and risk factors over the course of your clinical work with these patients. While it may feel sufficient to complete the measure and mark that it was done, this is not sufficient, especially when we're looking at appropriate trauma-informed care. Therefore, as you move forward in time with your patients, you will continue to discuss and address their experiences, the risk factors, and the manifestations of some of these experiences with them to allow you to provide timely and evidence-based intervention, support, and care. Prochaska and DiClemente established the model of readiness for change, upon which the bulk of motivational interviewing, intervention, and assessment has been based. While we use this with our patients to understand where they are in their readiness for change, that helps guide us to determine what type of guidance or even prescriptions we should give them after our visits. It's also applicable to us as providers. I encourage you as a provider to think about where you are in your stage of readiness for change. For many of you, you may have been practicing medicine for some time, and this may be a new and challenging, scary aspect of practice to start to implement. In thinking about your motivation and your expectations for positive versus negative outcome, this may help you decide where you are in your willingness to educate yourself, practice, and seek additional resources to increase your ability to have confidence in doing this very important part of clinical practice and facilitating trauma-informed care. It's important as a provider, beginning or continuing to incorporate ACE screenings into your practice, to be mindful of certain aspects of care that may not have been on your radar previously. It's your responsibility to follow the risk assessment algorithm and provide follow-up care on toxic stress mitigation and any ACE-associated healthcare conditions that you may encounter. These are guidelines to go beyond the risk assessment algorithm should the opportunity present itself and the provider, parent, patient feels comfortable continuing to dig a little deeper to further inform their care and intervention. This is all an important part of trauma-informed care. In the process of being mindful, there are certain prompts that you can give to patients that may open the door to further discussion and disclosure. Some of these techniques will be demonstrated later in this presentation in the form of role play. There's an importance to create a safe and supportive environment in which to talk about some of these experiences over the course of several visits. These are strategies that are applicable to everyone, but will require your own personal touch and adaptation based on your comfort and experience and on the unique characteristics of the child or family that you're working with. One of the most important aspects of doing screenings for ACEs is to inform prevention, early intervention, and identifying ways to mitigate the long-term impacts of ACEs on development and functioning. While it may feel overwhelming and cause you to feel helpless in learning about the traumatic or adverse experiences that your patients have had in their lifetimes, there is quite a bit that can be done, even in the course of a regular visit, to aid in early intervention and mitigating the long-term impacts of ACEs. While you may not be able to fix it and make it all better, some strategies that can be included in your trauma-informed care are things like teaching skills to help the parents and the youth handle stress, manage emotions, and tackle everyday challenges. You can connect the youth to caring adults and activities that maybe they hadn't thought of or didn't have access to. For example, finding a way to get a fee reduction or even a scholarship to some type of sports activity or outside event that may allow them to make connections with other people. Intervening in some ways to lessen immediate and long-term harms associated with toxic stress. Even on the macro level, promoting social norms that protect against violence and adversity, opening the door to talking with these things about your patients, and modeling the appropriate and supportive means of thinking about these things is a start. There are many evidence-based programs and clinical interventions that have been shown to really help in mitigating and treating the long-term impacts of trauma and adverse childhood experiences, including toxic stress. We know that building supportive relationships with appropriate adults, and in some cases, connecting children and families to mental health, are things that have been shown to be very helpful. There are programs available even to mothers expecting children who may have had their own adverse childhood experiences that will help prevent these trauma experiences being passed on to their children through their parenting. Additionally, there are parenting programs that are evidence-based that provide parents with tools and strategies, as well as their own coping skills to help them navigate parenting in an effective, supportive, and nurturing way, even when they encounter significant stressors. There are also many evidence-based trauma interventions that can be provided by a trained therapist, starting even with infancy, that again will mitigate and provide buffers for the child who is growing and developing in potentially adverse and stressful circumstances. When it comes to trauma and ACEs, the earlier the better, meaning prevention and early intervention. But it's never too late to provide appropriate care and support for somebody who has encountered these experiences in their lives. The key components of evidence-based treatment include engagement, building motivation, engaging in risk assessment, and tracking that throughout the course of treatment, providing psychoeducation about trauma, trauma triggers, and the way in which someone may experience post-traumatic symptoms, which can be different for different people, particularly depending on their age. Helping the child and family with skill development, things that they can apply to other stressful experiences in their life, modeling and practicing self-regulation and coping behaviors, and helping the family to establish routine, safety, and consistency to help with relapse prevention. Also helping the family to feel empowered to advocate for themselves, whether it be within their social relationships or in the community, is an important way to increase their sense of control and help them feel like they are not going to be victimized further. We also know that some of the longer-term structural brain effects of toxic stress during early childhood can possibly be mitigated through the use of SSRI medications, which specifically have been shown in research to potentially increase hippocampal volume and address hyperarousal and other physiological reactions to the fear response that may occur in particularly traumatized youth and individuals. While it may feel like an enormous responsibility and task to take on in holding this information and wanting to provide appropriate trauma-informed care. A little goes a long way, and there is a lot that you can do as a provider, even during the course of a regular medical visit. One of the more easily accessible and simple tools that you possess as a provider is to simply schedule more frequent follow-up visits. This allows you to be able to monitor and support the patient more frequently and continue to build that relationship so that you can provide appropriate trauma-informed care. In some cases, you may be the closest thing that they have to a stable, nurturing, responsive adult in their lives. And because of that, you can build upon this in providing them with more consistent check-ins. You can also validate their experience and move away from shame, blame, and punishment that the parent and or child may have encountered in other contexts of their life. It's important to show the child that they're not responsible for the bad things that have happened to them, that they're not born bad and that they're not bad, even if their behaviors may be considered bad. Sometimes it may be important to help the child and caregiver recognize that seemingly maladaptive behaviors can be appropriate and actually considered coping behaviors at the time in response to the stressors that they're experiencing, the context that they're living in, and in the absence of other options. Avoidance, for example, is one of the post-traumatic symptoms, and yet we all engage in some avoidance in order to be able to get through our day. If a child is highly avoidant, it may be that it was the only option that allowed them to continue to function in any way that was seemingly healthy and appropriate. And if they allowed themselves to think truly about what they were going through, it may render them helpless and hopeless and cause even greater impairment. It's also important to share that they are capable of change, and that even if this is a behavior that they have engaged in for some time, that with the help of appropriate provider and often a mental health provider, that they can bring about change and be successful in tackling some of the everyday stressors that they will encounter. Another thing that has been quoted many times, which I really think makes so much sense, is to shift from the mentality of what's wrong with you to what happened to you. It's really exemplifying that you're not looking at the child or the individual as broken or as bad, but more the idea that they must have gone through something difficult, or they must be experiencing something that feels difficult to them in the moment that causes them to act in a negative or disruptive way. And by opening the door to understanding what the cause is, you're already starting a sense of trust and respect for their unique experience, which is, as discussed earlier, such an important aspect of good trauma-informed care. As a psychologist, the bulk of work that I do is listening and talking with patients and families about their experience. It's important to recognize that sometimes just listening can be therapeutic. Once the unspeakable becomes speakable, it becomes tolerable. One of the people that I worked with for years, who was a pioneer in doctor-patient communication, always said, "A burden shared is a burden halved." And I have found this to be very true in my clinical practice, as have many of the medical providers with whom I work. As a psychologist working with traumatized youth and individuals in my practice, I often ask them what would help them to hear from me, from other providers, or from their loved ones that might help them bring back their hope and expectations to get better and lead successful lives. American Academy of Pediatrics in their toolbox offers the simple triad of reassurances that a provider can give them. Simply, you are not alone, it is not your fault, and I will help. While it seems quite simple, and it may even seem perfunctory, saying this often, even at the end of every visit, to a child or family will help them to recognize that it really is true and that you are there with them for the long run and can make such a big difference, and again continue to build that bridge and that relationship of trust and positive expectations in their visits with you. We all may have different understandings and subjective definitions of what resilience means, but it's important to understand where a family has come from in order to understand how far they've come and how we want to define and understand what resilience means for them. While generally speaking, resilience is the ability to withstand or recover from stressors and is a combination of intrinsic and extrinsic factors, we also need to recognize that there may be predisposing biological susceptibilities or vulnerabilities that a family brings that will need to be addressed in helping understand what the most effective intervention and mitigating support will be to increase the likelihood that they will be resilient and achieve their goals and success. Within the model of trauma-informed care, as depicted in the triad that was presented earlier, it's important to not only assess for the ACEs, but also consider the protective factors, the barriers that we know can help mitigate the impacts of adverse childhood experiences. Mental health and decrease in other behavioral and mental health expressions of trauma exposure in response to protective childhood experiences. However, we don't yet have the studies to know whether or how much these protective experiences will mitigate the effects of toxic stress when it comes to physical health outcomes. We can expect that there will be data coming from longitudinal studies as we continue to get further into the research on toxic stress. Finally, this is a simple but very important visual that highlights the 7 evidence-based strategies to mitigate toxic stress and their impacts. These include healthy relationships, high quality, sufficient sleep, balanced nutrition, regular physical activity, mindfulness and meditation, access to nature, behavioral and mental health care. While this talk is just scratching the surface and providing an overview of trauma-informed care and ACEs screening, we hope that this has been useful for you and that you will continue to seek further training, education, and practice on your own in order to move forward in providing such an important aspect of your role with children and families in the future. Next, we're going to show you some role plays that depict some of the concerns that have been raised by providers in doing ACE screenings in their practice. This first one will entail a provider-parent encounter where the parent is offended by the ACE screening.
Hi, how are you doing today?
Hi, Dr. Landon. I'm doing okay.
Well, I'm glad to hear that. I noticed that you didn't fill out the PEARLS questionnaire. I don't think we were using it last time you and Susie were here. Did the medical assistant explain it to you?
She did.
Great. So like she mentioned, this form asks about the exposures to adverse childhood experiences or stressful or traumatic events in childhood. Have you heard about ACEs?
Maybe. I'm not sure.
Well, we've started to ask all families about them because these experiences are very common and because we now understand that they can affect children's health and development. On this form, you do not need to mark which exact ones apply to your family on the de-identify tool, but your responses to the question will really help us to understand if there are things which may not be just medical that can affect your child's health now or later on in life so that we can help.
I just don't understand why I'm being asked to fill this out. I'm a good parent and my kid is doing fine.
Well, this is not a judgment on you or how you raise your family at all. And we are giving it to all families. We just really want to be able to provide better care for our patients on a whole person level. The questionnaire is intended to identify if there are things you might be struggling with or that we can try and help with. I know it may not seem like this has anything to do with Susie's medical health, but we know that it will help her and you if we catch some of these things early on and try and find ways we can support you and your family to decrease some of the risks that come with these difficult experiences.
Well, I already give my kid everything they need. I'm not sure how you guys would even help if there is a high score.
Well, it sounds like you're already doing a great job with caring for your children. If the score is high, that doesn't mean you aren't doing a great job as a parent. There are some things that you may not be able to manage on your own. No parent could, no matter how hard you try. There are ways we can work together to promote the positive things that are going on and maybe introduce some new helpful strategies for those dealing with stressful situations or connect you with some resources that could help. If the score is low, that doesn't mean there aren't stressful things that can happen. Being a parent and a child is stressful, especially these days. Would you feel more comfortable reviewing the questions now?
Okay, sure. That makes more sense. I'm willing to do that.
That's great. As you go through each statement, feel free to stop me at any point if you have any questions. Are you all set?
Yes, I've finished.
So really what we tried to do through that interaction is normalize the ACE screening. This is something that's now given to all parents under a California state initiative. It's really the screening practice and trying to make it part of the community and part of what every pediatrician, family medicine doctor, physician's assistant, and so forth are including in there. It's not based on any judgment of parent or family. It's just intended to identify areas for support, for reinforcing parents' strengths and so forth. So what we really want to be able to do is provide this alternative approach, review the questions orally, a little more informally, and identify that some people are having difficulties, particularly in this time of COVID, with childcare, school, food insecurity. That this places increased stress on the family. So this will allow us to really help to identify resources and schedule that follow-up visit, and maybe in a month to check back in.
These are just a few of the more prominent takeaways from this particular scenario. We will get to debrief on these and get your reflections in just a few moments. Effective screening takes sensitivity, patience, and follow-up. You have to commit to the process over the long term. Psychoeducation is an important component of screening. Practitioners can build their skills in anticipating and preventing negative perceptions in patients over time. Among the most important skills are empathy, flexibility, and the ability to listen. The second role play will involve a situation where there are concerns identified during the ACE screening that the provider does not initially feel equipped to address. This will be demonstrated by unspoken worry and hesitation prior to seeing the patient, but utilizes some learned languages to address the given situation.
Oh, let's see. Oh, the Smiths are my next patient. Looks like they filled out the pearls. Great. Oh boy. Well, this is interesting. It looks like the child has noted a lot of few things that this is kind of surprising. Parental substance use and food insecurity. Wow, that's never come up before. Well, this might be tough. We've never had to talk about things like this before. I just want to prepare a little bit. I'm going to look at my ask, tell, ask guidance here. I know that there were some good things to say to kind of initiate the discussion. Definitely not blaming, trying to keep it open, not accusatory, certainly not shaming the parent. This is a family I've known for a bit. So even though we haven't talked about things like this before, I believe that they trust me, and this may be difficult, but I feel okay about addressing it with them. So I won't start off right out the bat on that. This child is not the age where I would normally pull them out to do the heads exam privately. If the conversation goes a different way, maybe I will need to talk with the child privately, but for now, I'm really going to try to have this conversation with the parent and child in the room and have it be open. So, okay, I think I'm going to go ahead and start our telehealth session then.
Hey, Dr. Marcy, how's everything going? How's my kid doing?
Hi, I'm doing well. Good to see you guys. I'm happy to see you both here today. Everything seems to be on track and looks good.
Oh, that's awesome.
The MA just gave me your completed Pearls questionnaires. You guys, those things that you filled out before. Thank you so much for doing that. Is it okay if we take a moment to go over it together?
Sure. That's fine with me. Does that sound good?
Great, thanks. I really appreciate your time and responses. We're asking all patients to complete these questionnaires because some of these issues affect a lot of families, and they can impact your child's health and development. It's important for us to ask. We're trying to catch these things early. I'm sure you understand why the earlier the better, so that we can help kids and parents. I even filled this questionnaire out for myself, and I'm learning so much about how important it is to recognize how stress can have an impact on me and my health. Do you feel comfortable talking about our answers together?
Sure, that's fine.
Okay. So I noticed that you marked yes to a few of the statements. Are there any in particular that you would like to talk a little bit more about or feel comfortable talking about together?
Go ahead. It's okay to share.
Well, sometimes we don't have a lot of food in the house, and I have to go to school without a lunch.
Yeah, it's been a little hard recently. My hours are reduced, and as you know, his dad lost his job, so most of the money we're making goes towards rent and other bills.
I really appreciate you guys sharing this with me. This has got to be really difficult, and I mostly feel glad that you felt safe enough to talk about this. Our social worker has actually just talked to me recently about some great resources that I think might be a good fit. Would you be willing to let me connect you with her to get more information about some of those possibilities?
Yes, any help is appreciated. Thank you, Dr. Marcy.
Perfect. I will have her give you a call. You're doing a great job. It seems like you have a great support system, and we've talked about this a lot in the past, and we're always here to help in any way we can.
Yes, we do have a great support system, and thank you.
And to both of you guys, I also want to make sure we talked a little bit about your asthma. The stressful situations like the one you shared with me today, it's also very normal for your health to be impacted. How are things going with that?
He's had to use his inhaler a little bit more than normal, but it's not anything I'm too worried about.
Okay, that's great. Do you feel like you're managing your asthma okay?
Yeah, sometimes it's hard to. I forget my inhaler at home sometimes, but I felt okay.
Okay, that's great. I just want to make sure you're remembering to take your inhaler like we talked about, and that by managing the stress you might be feeling recently, it may even help out the asthma symptoms. Stress is very normal for everyone, and some of the things that have been shown to regulate the stress response in children include things like good nutrition, healthy sleep, spending time in nature, like outdoors. Sometimes we don't get outdoors for days, especially when we're online for so much stuff. Regular exercise, mental health support, mindfulness, and healthy relationships. I'd like to explore some of these with you to identify which we can use to treat your stress response, which we believe is contributing to the asthma. And there are a lot of strategies to sort of offset the stress response that we can have. Of all those that I talked about, which would you think you might be willing to try?
Maybe balanced nutrition and physical activity.
That sounds great. Do you feel like we need to make a plan on how we can use this strategy to help treat asthma and also balance the stress?
That sounds wonderful. That sounds great. We definitely could try some of these out.
Okay. Do you guys live in an area where you feel that it's safe and attainable to get at least outside for some activity?
Yeah.
Oh, great. Okay. Well, I think that's a really good place to start, and that really can help, head to toe with physical and mental symptoms and managing the stress, and even something you guys could do together. And I really just want to thank you both for dialing in today and being in this visit. I'll give you a call in about a week or so to check in on how you're doing with the asthma symptoms and incorporating some of these things like the activity and the balance of nutrition into your daily lives and your routine, as well as to make sure that our social worker has contacted you and gotten you those resources and services that I mentioned earlier.
Thank you very much.
Thank you.
You're welcome, guys. Have a good week.
You too.
Bye.
Bye-bye. During this visit, I was able to help the family talk about some of the stressors that they've encountered recently. You might notice that I didn't raise the child's report of parental substance abuse in the home. This was a deliberate decision on my part to not bring it up unless the child themselves or the parent brought it up during this visit, mostly because this is a new measure that we are using. And I felt that if I brought up something that could be a bit more challenging for them to discuss, that it could dissuade them from disclosing in the future. However, I also scheduled a follow-up phone call in a week, and will be sure to schedule another visit with the child and parent in the near future, at which point I may ask to speak with the child alone or bring it up during the parent and child encounter loosely to see where it goes and then follow up accordingly.
These are just a few of the more prominent takeaways from this particular scenario. Again, we will get to debrief on these and get your reflections in just a few moments. ACE screening and treatment of toxic stress is done because it improves clinical care. The provider can start the conversation and continue to engage with the patient in mitigating the effects of toxic stress as treatment for any ACE-associated health conditions. Being interested, listening, and caring is a sufficient, important, and necessary first step that should be possible for any provider. Jointly developing a care plan that identifies evidence-based strategies for toxic stress mitigation and making necessary medical, mental health, and social service referrals is an appropriate next step. Thank you so much for tuning in. We'll now transition to the reflection and question and answer portion of this presentation to give you all an opportunity to share your thoughts on the scenarios we just watched and ask any questions you may have.
Thank you so much, Dr. Marcy, for that informative presentation. We'll take just a few minutes to go over some important reminders about ACEs training, certification, and screening. So if you are a clinician who bills Medi-Cal, you must complete the Certified ACEs Aware core training and attest to completing it to qualify to receive Medi-Cal payment for conducting the ACEs screenings. And there's a link here in this bullet for becoming ACEs Aware in California and that training. It's a free 2-hour training, and you'll get certified so that you can receive that payment from Medi-Cal. And also you'll receive 2 continuing medical education credits, or CME, 2 maintenance of credit certification credits, and also others are able to receive CEs as well. We'll now go ahead and start the Q&A portion of this presentation, and we'll be able to debrief these scenarios we just watched, ask any questions that may have come up during the presentation or those role plays, and please submit your questions via the chat box for Dr. Marcy to answer, or you can raise your hand and we will call on you to have you unmute. And please go ahead and keep typing questions into the chat box as we go along.
I will just say, while people are thinking about their questions, I think I alluded to this in the talk too. This is a very brief sort of snapshot and overview. I realize for sure that it sounds, it sounds a bit condensed and easy, and definitely tried to incorporate some of my real life experiences into it. And it would be nice if everything went as neatly as we hope it will, but it's just to sort of get everybody thinking about doing these things and address some of the concerns and reluctances people may have.
Yeah, I really liked how you covered how you were sensitive to some of the topics that might be hard to address in that first conversation with someone, and had them come back a week later so that you could talk about those things that might be a little bit harder. Okay, Chaz Brewer has raised their hand.
Hello, Lucy. Hello, Dr. Marcy. I appreciate the presentation, and I definitely appreciated the role play scenarios. My question is, so with the last role play, I know you definitely explained and articulated how you deliberately didn't go into the substance abuse. And so my question is, I know we try to encourage team collaboration. So how do you foresee this thing play out? I know you had mentioned that you would follow up with the family and maybe bring it to substance abuse, but can the social worker who's going to follow up, can they also engage and try to address the substance abuse, or is it something for just a provider, in this case being you, the physician, to follow up on?
That's a great question. And you know, in my clinic, we do have integrated behavioral health with, you know, social workers that are also, you know, social workers that are licensed therapists that have the skill set to be able to follow up. I think it's important that we are mindful of the scope of practice, and that we do not put other, you know, team members or professionals in a position of asking about things that they're not trained or equipped to follow up with. So if we're talking, you know, if it is a trained professional, in this case, that is a clinician, social worker, then I love what you say. And I think it would in some ways possibly be appropriate if we sort of said, hey, is it okay if I refer you to one of our team social workers / therapists for follow-up to, you know, continue to address maybe some of this stress. But in this exact scenario, sorry, getting over colds. In this exact scenario, I think I would rather keep it something, you know, the subsequent discussion with me, because I don't want to start to add too many other people to the discussion and increase the risk of the family, you know, feeling ashamed or being afraid that they've done something wrong, or that there's going to be, you know, something punitive. So in the second visit, that might be the time where I would say, you know, I also want to bring this up. I want to talk with you guys more about it and understand, you know, make sure everybody is safe and understand a little more of the context. Hey, mom, is this something you'd feel more comfortable talking about without, you know, your child, or vice versa, sort of reading the responses and then potentially referring to a trained professional that could provide the additional assessment and intervention. Does that answer your question?
Yes, it does. It does. And, you know, part of why I ask, I know, especially now, resources, especially healthcare, you know, are a lot of providers feel, you know, stretched pretty thin. So, you know, using that team collaboration, I was wondering just how that would be incorporated in this situation, but you answered it very well. And like you said, I guess keeping with the scope of practice is best. Well, thank you.
Yeah. And I think one of my big messages here is that by having, I mean, so I was playing the role of a doctor in that, but I'm a psychologist. I'm not a physician. But the idea also is, I try to train in my setting at Children's Hospital LA of it shouldn't just be that the physician's role is so limited that the second they hear something psychosocial or behavioral, that it's like, okay, send to the mental health professional. So I want there to be able to be some comfort in having some of these more difficult discussions and then being able to determine what the next steps should be. And when it is important that they see a trained mental health professional, but that doesn't mean they're, you know, trauma-informed care is incorporative, and it's usually starts with the primary medical provider.
Great. Thank you, Dr.
That.
Marcy.
Thank you.
Thank you, Chaz, for a wonderful question. I'm going to go ahead and read a question from the chat, and please do go ahead and chat in anything or raise your hand if you've got a question for us. So when we screen children for ACEs, we may suspect that a parent themselves also has a high ACE score. How can we work with both generations to support parental resilience and avoid blaming or offending parents?
That's a whole, you know, hour lecture in itself. And, you know, we know data on epigenetics of trauma and toxic stress. And I think it is, important that we apply the same principles, whether, you know, developmentally appropriate, but contextually appropriate in, it may come out during the discussion with the pediatric patient that they're experiencing these things, and we can read some of the verbal and nonverbal responses from the parents that that there may be what would I say, like more an exaggerated sense of guilt or blame or responsibility or some of those things, because, you know, a lot of parents will tell me that they
sort of made a vow to themselves that they would never have their child have to go through what they went through. And so I think it's important to recognize that the parents are there as, a former child and a child that had perhaps a history, and also as a parent of a child. So they're carrying both the burden and the responsibility and then their own history. So I think to be, transparent about it and be selective in your language. And we certainly don't want to normalize or validate abusive experiences and things like that. When they are hurting their children, we have to respond from a safety perspective first. But I think there are ways to offer the parent resources or some private time to talk to you, to sort of debrief a little bit about it and initiate some of the discussions, not as assuming, but also saying, hey, I'm somebody that you can talk to that is not going to judge, but really be focused on trying to help. And I'm going to be sensitive to these issues. And I recognize that that there are choices that are made for you or things that happen to you that affect your ability to maintain that same level of consistency and safety that you vowed to have for your child. Hey, you brought them in today. That's a start, and you answer truthfully, or you encourage your child to answer truthfully. That's a start. And then start to think about the different things that we can connect that parent to that may be separate from the family or the child. Finding resources for adults that may be in the community. In our program, we in our larger clinic, there are providers for adults, but that may not always be the case. So finding resources for either telehealth or in person, maybe they can talk to somebody. They may not be ready to go through trauma-based treatment and unravel everything that they have, but at least giving them some access to support when they're ready, and also not making it a contingency or make them feel that they have to go, spill their entire history and get therapy in order to be a good parent. And it does require ongoing discussions about it, but at least to know that you're somebody that they can confide in to that degree, and that you will not go outside of your scope of practice, but do your best to connect them with resources for people that can be helpful to them.
Great, thank you. And I think that's such a good point about acknowledging what parents are doing and their best intentions and their heart and their actions that are, toward the betterment of their child's health. Thank you, everybody, for your good questions. And I hope this has been helpful. Thank you for a great lecture, and I hope that it's useful in your work in the future. Please stay on for some important reminders from the Landon Pediatric Foundation and the ACEs grant coordinators.
Thank you again for watching this lecture. Remember to complete the registration and evaluation. We will contact you soon if you are one of our raffle winners, so stay tuned.
Make sure to follow us on all our social media accounts and subscribe on our webpage for more information of our 12 lecture series, ACEs Aware Ventura County, and all things ACEs Aware.
Thank you for joining us on our mission to bring better health, and better hope to Ventura County and beyond.
Bye. See you at our next session.
Thank you, everyone, for joining this afternoon. And thank you again to Dr. Marcy for that awesome presentation. We will welcome any follow-up questions. You can email us at acesaware@ventura.org, and we'll forward them to Dr. Marcy if there's anything pressing. You can also visit our website at acesaware@venturacounty.org. Our next session is Unit 2, Session 3 on Wednesday the 13th, which is a follow-up of these motivational interviewing sessions, decoding the ACE screening tools and scores. That's with 2 of our local pediatricians here. So visit our website if you'd like to register for that session as well, and we look forward to seeing you on. Thank you all again, and thank you, Dr. Marcy.